Hello, everyone. I'm Amy Zelmer from Faces of TBI, and welcome to the Brain Injury Online Summit Training Series. I myself am a survivor of a TBI from a fall on the ice in February of 2014. And myself, along with Dr. Jeremy Schmo from Minnesota Functional Neurology, we came together because we saw a need in the brain injury community for more training and education on alternative healthcare methods and modalities for those that are still suffering from the lingering effects of a brain injury. Our goal is to help educate and bring awareness to this invisible injury that affects 2.8 million Americans each year and is the leading cause of death and disability in the world. So each day you will be seeing 4 to 5 presenters who are going to share their experience either working with brain injury patients, or they're going to share their real life experience of living with a brain injury. And today I'm here with Dr. David George, and he is a med tech entrepreneur, an inventor, educator, and clinician focused on innovation in the field of clinical neuroscience. His areas of focus include neurorehabilitation, as well as neurodiagnostic and neuromodulation technologies. One of his most rewarding projects is FNOR, Functional Neuroorthopedic Rehabilitation. FNOR is a disruptive neuroscience-based physical rehabilitation system that is designed to treat persistent pain more effectively. Chronic pain is one of the major challenges in modern healthcare. By integrating current evidence in the fields of orthopedics, neurorehabilitation, biomechanics, sports medicine, and even complementary and alternative therapies, it is hoped that the FNOR system will bring new hope to pain sufferers, including those suffering from persistent joint pain, failed back surgery syndrome, chronic spine pain, and other common causes of treatment-resistant pain. So welcome to the summit. I'm so happy to have you here, David.
Thanks for having me, Amy. I appreciate it.
And so today you're going to be talking about a new approach to physical rehabilitation for chronic pain, stubborn injury, and pain after surgery, harnessing the nervous system for pain relief. So I am really excited to hear what you have to say, because chronic pain is a major component of most brain injuries and concussions.
Well, Amy, thank you very much, and you're absolutely right about that. And it's one of the most underappreciated kind of associated things with brain injury. When a person has a brain injury or a concussion, any form of trauma to the brain, that's a medical emergency, and that becomes the emphasis of care and of rehabilitation, as it should be, because of course that brain is keeping you alive. But one of the most underappreciated elements that's frequently associated with brain injury and concussion is chronic pain. And that is because, for one good reason, and that is that the processes of chronic pain are associated with changes in the nervous system, both in the peripheral nervous system and in the brain. When people think about chronic pain, or let's take a simple condition like a common cold, for example. When you think about a common cold, we have a bunch of symptoms that are associated with that. We have the runny nose and the sore throat and the headache and the concentration difficulties, or even migraine, for example, which is a painful condition. We have the sensitivity to light and the sensitivity to sound and the nausea and the movement and the sensitivity to touch. Or even Alzheimer's disease, where we have loss of smell and irritability and loss of memory, and we have these list of symptoms. Yet when people approach pain, they approach it as kind of a unimodal thing. People have pain, like that's the only problem. And what neuroscience is showing us in recent times is that the chronic pain process is actually associated with an equally long list as many of these other conditions. Changes in the brain, for example, in the centers that control concentration and emotional regulation and balance and sensitivity to different sensory stimuli. And that's kind of not only a fact, but it's also an opportunity in rehabilitation. In short, what this presentation is about today is based on, my experience as co-founder of the FNOR system wherein we've kind of integrated orthopedics and neuroscience because it had to be done. And I didn't come at it through the brain injury channel, although I do have experience in neurorehabilitation, much like many of the practitioners that you've brought into your summit. But my channel came through trying to rehabilitate failed back surgery syndrome patients. Now, for those of you that are not aware of what that is, failed back surgery syndrome is one of the most problematic entities in chronic pain. Essentially, what failed back surgery syndrome is patients that undergo spine surgery for pain and for some structural problem in the back. And by all accounts, the surgery is successful. It's a successful surgery, yet after the surgery, statistics show that 10 to 40%, somewhere in that range, and possibly more, of patients that get some type of surgery of the spine will actually end up being in the same amount of pain or, in fact, worse after the surgery. And once this happens, these patients are essentially left with no options. So myself and my the other co-founder of Functional Neuro-Orthopedic Rehabilitation, Dr. Stuart Fife, is a doctor of physical therapy. We saw this problem, and this is the population that we decided to work with, was this failed back surgery population, very resistant to physical therapy, very resistant to essentially every pain treatment that's out there, and essentially a growing number in the hundreds of thousands per year, at least in the United States and then certainly internationally. So what we decided to do was focus on this population and try and learn from this population, say, look, whatever measures we can develop to treat this population will probably be beneficial in patients that are less complex and less problematic. And where we ended up was, over the years of developing the system and working with different methods in treating these pain patients, which were emphasizing the non-invasive and de-emphasizing the pharmaceutical and invasive, because essentially just about every patient that came to us through this kind of initial group that we were working with in failed back surgery had multiple surgeries and multiple interventional procedures, and essentially nothing had worked, and they were left in a great deal of disability. So basically, we started developing the system and found that we were necessarily confronted with the nervous system and the brain. We had to get to the point where we realized that these patients that had this pain, a lot of what was causing the pain to persist, because a lot of them had very successful surgeries. As I said, they saw very skilled surgeons that had performed beautiful surgeries, nothing wrong with the surgery, yet their pain persisted. And we found that when we addressed the nervous system, the peripheral nervous system, and the central nervous system, the brain, we had results that were, we believe, as yet unseen in the world of pain management for these problems. We started to have very, very good results, and we started bringing a lot of relief to these patients when we started looking at the brain. Now, what's interesting is when your summit, I believe, is all about concussion and about brain injury, and this is a kind of a two-way street. A lot of the people listening to this might be associating with this by saying things like, you know what, I do have bodily pain. I have shoulder pain, and I have back pain, and I have headaches, and I have migraines. And the way that they might have been treated to this point was either that the pain is almost less important than some of the other symptoms that they might have had as a consequence of the brain injury, or somehow unrelated. Mm-hmm. And from our perspective, these problems are often very, very closely related, in fact, stemming from the same well. Chronic pain in the United States is a extremely costly problem. It's more costly than diabetes, heart disease, and cancer combined in terms of the cost drag to the system. So much so that in 2010, the Institutes of Medicine looked at a report, started developing a kind of an investigation and subsequently produced a report on the problem of chronic pain. And they found that there's basically a system-wide failure in how we're addressing chronic pain. That generally the practitioners that are seeing the problem are not really sufficiently trained. A lot of primary care practitioners really don't get a single class in chronic pain in their entire training in medical school. And that's true across the professions. So it stands to reason, it's reasonable then that a lot of practitioners that are dealing with pain wouldn't catch that association between the nervous system and the pain, such that this chronic pain process is very often a nervous system problem. So what we did after this was that we developed a system called Functional Neuro-Orthopedic Rehabilitation that basically was a neuroscience-based approach, where we said, you know what, let's start with the nervous system, let's start with the brain, and let's start from there and see if we can apply some of the rules that we've learned in neurorehabilitation to our approach to pain. And the results were phenomenal. But more so than just reducing people's pain, what we found was that not only would someone enjoy less pain, but that actually also, as a consequence of it being a neuroscience-based approach, would be more focused. Their memory would improve. They'd wake up feeling better in general about their own person, connecting better with others. They were moving better. They were stronger. So when we approach the brain and put the brain and nervous system at the center of the hub in terms of, no matter what your pain problem was, whether it's back pain or shoulder pain or headaches or whatever it was, we found that by improving brain function, it's kind of a shotgun approach. Everything started to improve. And I think this is the way that the field is going. Although this hasn't trickled down into the world of physical therapy yet, where it's actually brought down into practical solutions, and that's where we are. So, one of the things that I think is being missed in kind of rehab is that, most people that are suffering from pain are suffering from it for more than one reason. So, for example, a lot of brain injury folks and people that have gone through brain injuries and concussions, those changes to the brain are not without consequence in how you move. There's subtleties in how your body's, because the motor centers are affected and your balance is slightly affected. The way you move changes, for example. And when the way you move changes, what that starts to lead to is changes in how you compress the spine, for example, how you compress the shoulder, how you compress the hips. And then you start developing these aches and pains that over time, promote inflammation and promote discomfort and eventually lead to changes in the joints. So, it's kind of like a two-way street. When people have the brain injury, it changes the way they move, and including, by the way, just being less motivated to move in general. But the change in movement also leads to changes in the brain, because your brain is so dependent upon normal movement. What we find in the brain is one of the things that I talk about in my lectures, and which will probably be quite familiar as a concept to many of the practitioners that you have on the summit, is that those functions that make us human, that are unique to us as humans in our brain, that separate us from other species on Earth. For example, the ability to concentrate, to reason, to predict the future, to be analytical, to interact with others, and indeed the kind of foundation to a lot of our social functions are housed in the newest parts of our brain. And those newest parts of our brain that are uniquely human are, in fact, the most fragile parts of our brain. So when we have brain injury or we go through these structures, those newest parts are most vulnerable and they start breaking down. Well, the same is true of movement. A lot of people think of movement as, okay, just the ability to move or balance. But movement itself is broken down into these different categories that when we have a brain injury, there's different qualities of movement: the control of your muscle tone, the ability of your muscles to relax when they need to relax, the ability of them to brace up when they need to brace, the ability to move quickly, the ability to adapt your movement quickly. These are all subcategories of movement that are vulnerable as a human being. And where they're most vulnerable is in the bipedal posture, because that bipedal posture, the ability to stand on 2 feet, is very unique to humans. And as a general rule in neuroscience is that those functions that are unique to us as humans are most vulnerable. And that includes the ability to stand on 2 feet and move 2 feet. So that two-way street happens is that when we injure the brain, the way we move changes, and then the way when we move changes on 2 feet, that starts affecting the brain. And that can actually, particularly when you have a concussion or brain injury, lead to a further downward spiral in your brain function. So kind of as a take-home, what I would suggest to those people that are suffering from bodily pain and do have a brain injury is one of the worst things that you can do is take the old school advice of, take it easy, sit on the couch, don't do anything, and recede from activity. Because what the evidence suggests that that process of receding from activity, from backing off, is in fact, in the long term, at least as far as the health of your body goes and the joints and the bones and chronic pain, is actually one of the worst decisions that you can make. So as a strategy, generally speaking, for people with bodily pain, and particularly people with brain injury, concussion, and bodily pain at the same time, it's a good idea to look at strategies and develop strategies with a therapist wherein perhaps you're looking at, engaging in movement in bite sizes that you can tolerate, but generally keeping on track for increasing movement and increasing activity over time because of that relationship of the body to the brain. Another fact is that may be familiar to a lot of the people on here is this idea that we realized is just like emotional trauma. When it comes to the body, people deal with trauma differently. And a lot of that is based on how your nervous system is at the time in which you get injured. So, some people, one person with a knee injury could, tape that thing up and be back on the field in, 4 to 6 weeks and be in great shape. Another person and that might be a career-ending injury, and both of them might have very similar characteristics when we look at it on an MRI, or we do our standard orthopedic tests. We believe that has a lot to do with the nervous system, and it has a lot to do with those elements that are as yet in the field of orthopedics unappreciated. So what that basically means is not all people respond to emotional trauma the same. They don't respond to bodily injury the same. And a lot of it has to do with the nervous system. Well, that's an opportunity, because what that means is that if you undergo a particular injury or you're in bodily pain, you have opportunities to control what your nervous system is exposed to. And that could either be a net positive effect or a net negative effect. So in general, controlling things of like how you're thinking, the thoughts and the concepts that you have around your injury or around your recovery are very important. They actually literally play out in your body. If, for example, an anticipation of a negative outcome to your particular injury is very devastating for an injury, or fear around your injury, fear of re-injuring yourself, or fear of getting back into that space where you're re-injured, is a devastating effect on the body. In fact, in simple terms, one of the ways that you respond in your body to fear and anxiety and fear of re-injury is that you take on this what we nickname in our FNOR approach the overbrace posture, where you're basically very braced up and you're resistant to movement, and that's being reinforced by this concept in your head that movement is going to be injurious or you're going to injure yourself. And that leads to increased compression in the joints. And one of the parts of the body that's most vulnerable to that is actually your back. So in a lot of cases, when we have people that are coming in with chronic pain, one of the things that we're going to do is to work with their concept of their injury and what they're thinking, because that goes by many times unappreciated in the rehabilitation environment. We see people moving abnormally, and the assumption is that it's something that's a mechanical problem, but a lot of times it has to do with their concept of what happens next if I am free to move, or if I am there to move. So this is how these domains of psychology and neuroscience and orthopedic rehabilitation start to merge. You know, another kind of point is big for us in our therapy is that, you know, changing chronic pain, just like changing your brain, that's familiar to a lot of the people listening, it requires intensive therapy. The only way that your brain changes is your brain changes with focus, with intensity, and with persistence. The same way that you learn to ride a bicycle or you learn to do anything in life is that focus, intensity, and that persistence of effort is what causes the brain to go through those plastic changes. And the same is true in chronic pain. Yet, unfortunately, this particular approach is not well adapted in the field of rehabilitation, where we still kind of inherit these ideas from gym training, where we're going to be, you know, take it easy with this individual because they might harm themselves if they do too much. And so there's these 3 sets of a gentle 10 or 5 sets of, you know, whatever. And it's unfortunately for a lot of chronic pain sufferers, rehabilitation is not intensive enough. So the kind of approach that we take is it's necessary to understand the nervous system a little bit better, so we know where to focus that intensity in a very intentional and focused way to drive those brain changes in a safe way. But you know, if you look at each of those 3 factors that I just mentioned, and that's that intensity, that persistence, and that focus, those are 3 opportunities to dial up and down the variables that could make it useful for you to overcome a brain injury, a concussion, or to help reduce your pain. You can change your brain by being focused on the outcome, on a positive outcome, focused on developing a certain skill that wasn't there, you know, being aware that, listen, I'm focusing on developing this for right now. I'm being very engaged in any task that you're engaged in, and to engage in it with a great deal of intensity and focus, and then to do that repeatedly over time. Those are 3 factors that you can kind of play with in brain injury to create those changes, and we actually use them in the rehabilitation environment. So, you know, in terms of some of the other factors that we've kind of developed, is we also realize that a lot of the rehabilitation that's out there is actually counterproductive in terms of what we now know about the brain and chronic pain. And one of those factors is in reference to what's called network theory in brain, and that is that as you're listening to me right now, and I exist kind of outside of your intrapersonal frame of reference, and you're listening to me, I exist as an external concept. You're listening to me outside, and even though it's all been processed internally, you see me as an outside thing. Now, if I, as a therapist, am yelling instructions at you right now to, you know, bend forward, or pick that up, or straighten your legs, or straighten your back, and we give all these instructions, and you take this external focus where I'm giving you instructions and you're responding to those cues, for a lot of chronic pain sufferers, that's actually driving what's called the central executive network, which is basically an externally focused network in your brain that's kind of looking to your outside environment, processing things, and kind of organizing your behaviors and thoughts around that. It's a simplified view, but that's more or less what it does. But when it comes to chronic pain, the central executive network is kind of opposed to another network in your brain called the default mode network. And the default mode network is a network that is most active when you are kind of unfocused and receptive, and less engaged in a particular task. It's a part of the brain that is engaged, for example, in mindfulness meditation, and in some of the mindful aspects of yoga and these sorts of things, where you're in a kind of a receptive state, and not focused and not externally focused, and more receptive to what's going on in your body. That's that particular network, which, by the way, is activated right before you fall asleep. It's important for you to sleep. That network appears to be distorted in most people with chronic pain, which is why we see a lot of people in chronic pain that have a hard time sleeping, that feel that they don't really belong in their body. They feel kind of just disconnected from their body. And these statements might be very familiar to people with concussion and brain injury. They don't have that body ownership and that connection with their body. The same is true in chronic pain, again, because the processes that are associated with chronic pain are in many cases identical and overlap with those processes in brain injury, which is why we see one with the other. And this is not a unfamiliar concept when you consider and you think of a stroke patient, or somebody that's really injured the brain, or a spinal cord injury patient. You see those changes in muscle tone. You can recognize those as abnormal movements. Or somebody with Parkinson's. As a matter of fact, Parkinson's patients are up to 4 times more likely to have shoulder injury than other patients. Shoulder injury and pain is very commonly associated with stroke. So it's well known that that pain and bodily pain is well associated with many common pathologies that are out there in the nervous system, and that's because there's an overlap in these things. So that's kind of a summary of kind of how we see things, and kind of some of the opportunities that we're taking to really beef up the world of orthopedic rehabilitation, taking a neuroscience-based approach. And I think we're seeing some good benefit from it. I think we're hoping and working towards a world where we think that the tip of the spear in terms of pain rehabilitation is dominated by therapy, by physical therapy and non-invasive options rather than the invasive options. Because one of the unfortunate things, as I kind of wrap up here, Amy, is to say that the way it is in modern healthcare is, unfortunately, because it's not that way, because it's dominated by a kind of a medical paradigm wherein people are given treatments one at a time, and they're given them in series, and a kind of a wait in between to see how you respond to it. And it's understandable, because there's a lot of cost in just throwing therapies at people, and being conservative is generally a good thing. But if you're not appreciating the nervous system, that the fact that oftentimes the nervous system is winding down in the background, and it reaches a kind of a point at which when the breakdown in the nervous system coincides with the breakdown in the body, and then people have long-term problems. It's kind of understandable, but we're looking for, kind of a different approach to pain, where the first therapy is non-invasive, it's intensive, and it's brain-based. And we think, whereas, we look at a lot of pharmaceutical options, you have your list of side effects that are associated with those. And don't get the impression that I'm bashing on pharmaceuticals or surgery as an alternative. Like I said, in many cases, you've got these brilliant surgeons that do brilliant surgeries. But the reason that the people are ending up, we believe, and we're starting to show that in some studies that we're doing right now, is that we believe that the reason that the people end up with pain post-surgery is that the processes that led their body to break down, the discs and the joints, for example, that break down in the spine, the processes that led them into that point are not resolved by the surgery. It's like looking at your wheel alignment. When your wheel alignment's off and the tire blows out, you replace the tire, but now the wheel alignment's still off, so you're going to end up with the same problem, which is why we believe that a lot of this recurrence happens. And we think that by focusing on the brain, by taking the opportunity to look at what's in the research these days, which is a ton on brain, we end up with a therapy that doesn't have side effects. It actually has positive side effects, in a sense that along with somebody losing their pain and moving better, they actually have a brain that's functioning better. We think it's a more sensible approach to rehabilitation. It's more personally focused. It's more customized to the individual, in the sense that we approach each nervous system individually and see the opportunities that are there for us. And ultimately, the brain only knows one thing, and at a cellular level and at a global level, the brain knows to transform. That's how you get through things. You don't reduce pain by switching a switch off and you no longer have pain. You don't get over your brain injury by flipping a switch and suddenly your brain injury is not there or your concussion is not there. What happens is through hard work, persistence, and belief, and moving in a positive direction, those cells, literally the cellular level, are transforming the individual that you are, such that when you recover and you are having symptoms that are no longer there, or you have good function that comes back, you are literally transforming as a human being. You are a different human being at the start of your problem than you are after your problem. You transform. And that's how the nervous system works. And we think that's the opportunity of a rehabilitation approach that kind of looks at it the way that we're looking at it.
I found it interesting what you said about how someone with a head injury often has, the dizzy balance, and they don't know where they are in space, so they're walking differently. And I know when I fell, I had whiplash, I tore muscles, I dislocated my sternum. My body was like twisted and hunched over for like a year and a half. And when I finally found Jeremy, like the first thing he noticed was my gait was totally, completely off. And just reteaching me how to walk properly just changed so much of my pain problems.
Absolutely. And Amy, that's I'm glad you brought that point out about walking, because again, walking, by that definition that I gave you earlier on, is very unique to us as humans. We are essentially the only species that walks on 2 feet. We don't have a tail to balance us out. So a lot of that balance that we get on 2 feet comes from the muscles around our hips and, around the upper part of our legs and our back. And what happens consistently, we believe, in brain injuries is that how those muscles are activated starts to break down. It's almost as if people forget how to use those muscles. And walking is a kind of what we call a reflexive pattern. You don't use a lot of brain to walk. You don't have to think about walking. It happens reflexively. But when you have injuries in the nervous system, that reflexive pattern changes. And when it changes, it's kind of ingrained there. It's not like you wake up one morning and it's good and another morning it's bad. People have these abnormal walking patterns. Now, why, for example, in the context of a back or a knee or a hip, one of the reasons that it's important to walk properly is because you have, with every step that you hit on the ground, there's something called a ground reaction force. And that's a force coming back off the ground that kind of vibrates and transmits through your body into the joints of your back and your knees. Now, if you aren't controlling your muscle tone when you walk through your hips and your knees and your legs, literally every step that you're taking is jarring to your body, and it's aggravating the things that you spoke about, your back pain and your hip pain, and even to a certain extent your sternal pain. We find that a lot of people with shoulder problems have those problems are, even though it might not be primarily caused, they're maintained and aggravated by the fact that they aren't walking properly. Walking is uniquely human, and when we find that we can restore somebody's ability to walk properly, so many good things happen. And one of the good things that happens is they're more motivated to move around, right, which is in itself therapeutic. But also, with every step that you're walking, you're stimulating your nervous system. And that walking pattern is at the foundation of so many things, at the foundation of all movement in your nervous system. It's almost like it's the fire in the steam engine of your brain, that movement and that very basic movement. So that it stands to reason that you enjoy benefit from that. And that's kind of a very heavy, when people come in, we digitally analyze their gait pattern using certain technologies, and we can actually freeze frame and slow down their gait. And we really get down into very detailed analysis of gait because it is so important.
Mm-hmm. And I know, my whiplash triggered a lot of headaches. Mm-hmm. And as the patient, you don't always understand where the pain is coming from. And they got in and worked on my herbs point and my neck, and like all the way down through my shoulder and down and through here. They were barely touching me, and I was like, ah, so a lot of the pain is like nerve pain. We think it's all muscular, but it's not.
Actually, Emmy, yes, and what you're describing is our techniques that we use in FNOR, and we train our practitioners to use. And that's called peripheral neurogenic inflammation or peripheral neurogenic sensitization. And that's whereby these very tiny nerves so close to your skin, and those are the things that Dr. Schmo was touching on, you very close to the surface of the skin, become very sensitized and very painful. And because the pain is so intense and it's just so persistent when you move, it's often misinterpreted by doctors as actually coming from your spine or coming from your joints, because you describe it as very deep and very painful, and it's aggravated by where you move, and it looks a lot like joint pain. But where it's coming from is these tiny nerves very close to the surface of your skin. So that's actually one of the first things that we look at. Now, what I said to you is that in the EFNO approach, we look at central nervous system, and I think you and I have discussed that quite a bit today, but the peripheral nervous system is extremely underappreciated as a cause of pain. As a matter of fact, if I even slightly cut your skin, for example, to do a surgery, or you have an injury, your peripheral nerves start dumping all these inflammatory chemicals all around your injury, and that starts sensitizing the area. And for many people that have persistent pain, that process never ends. That process of inflammation and pain persists, and that's in your case, it sounded like it. But when we think about your particular case, for example, where your neck is so sensitive that you're really hesitant to move, it's really, really sore. Well, that's a real problem, because as you may understand, that the vestibular system, that system that senses the movements in your inner ears, your neck muscles actually have little tiny sensors that feed into that system to say where your head is in space. And your ability to move your head and your neck is very, very important for not only for balance, but also the overall level of excitation and stimulation in your brain. So if you have a situation that's limiting the movement of your neck such that you don't want to move your neck and you're getting into this brace, not only is it going to further aggravate pain in your neck and your shoulder region, but it's also going to reduce the overall activity of your brain, further aggravating the symptoms of your brain injury. Yep. So this is an example of this case where the pain turns up and people are like, oh, well, Amy has a brain injury and she has pain, and they treat them as two separate problems, but actually they intersect. Is that we have to get you out of pain as fast as possible so that you can engage in those activities to start rebuilding your brain. So that's why we treat pain as a priority. And unfortunately, a lot of practitioners, and this is a bit of a dark secret in the world of healthcare, is that we are very poorly trained on pain. In fact, if you were to ask any doctor that's out there, your class on pain in school, how many hours do you spend on that? I think that most of them are going to admit 0. Because there is no medical school class on pain, in most programs. So a lot of practitioners don't understand pain and they run from it, and their only treatment for pain is the stuff that they've been trained, the interventions. So it'll be the pharmaceuticals or the injections or physical therapy, but they don't understand the pain process. And as a consequence of that, unfortunately, a lot of people remain in pain and they remain untreated.
Yeah, and that's a great point. My neurologist wanted to do injections in the neck. And I wasn't ready for it. Like, I was like, no, doesn't sound fun.
You don't wake up in the morning reaching for your injection and wishing that your day was better.
But what you were just saying, when my neck does flare up, that is when I'm foggy, my balance is off. If I have a really bad, and I don't know if you'll touch on this at all, but the weather, when the barometric pressure drops, my neck hurts. And I get fuzzy and foggy inside, and that whole balance and woozy thing, and then the headache kicks in.
Yeah. So, a few things. There's a few items on the table there, and this is a conversation much longer than what we have right now. But staying with the peripheral sensitized nerves, is that one of the theories that we have based on our experience is that actually your long, thin nerves that I was describing about almost act as pressure sensors in your body. And why we think this, and this goes against current understanding in neuroscience and neurology, because what acts as pressure sensors in your body are receptors that sense pressure. But we actually think that the coverings, if you can think of them as cling wrap coverings around nerve that we call perineurium and epineurium, we think that these coverings of the nerves themselves, they are innervated with a structure called nervi nervorum, which is a nerve that innervates a nerve. And so that means that the skin of the nerve, we think, has the ability to act like a stretch and pressure receptor. And when it's sensitized, just like when you have a cavity in your tooth and one of the nerves is exposed, you don't sense those nerves when your tooth is intact, but when your tooth is exposed, you sense that nerve. And in a similar way, we think that these peripheral nerves become sensitized, and now they're actually sensitive to everything. They're sensitive to the pressure, and they're sensitive to movement, and they're sensitive to environmental pressure, and they can be triggered. And I will say one other thing about these nerves is that a lot of these tiny nerves, they're peptidergic, sensory nerves, is that they actually are associated with parts of your brain. Because you see, the pain experience is more than you just sensing pain. The pain experience is also you attributing through your brain a negative connotation to the pain. So if I slam my finger in the door, my brain and on the opposite side says, okay, you hurt your finger right there. But another part of your brain says that's a negative experience, and I kind of feel nauseous. That's negative, and I feel, and actually that's an example of how people will act differently towards it. And by the way, for those of you that are out there, females handle pain much better than males. Okay, so generally speaking, anyone that works in pain, I had to accept that truth 10 years ago, but it's a fact. So for example, just in that if we delineate it that way, females will experience it one way and men will experience it another way. But people experience it, but there's a second system that gets activated, and that's associated with what's called your limbic system. And these fibers fire into your limbic system, and they start giving, all those negative connotations that you have with pain. Now, when you have the sensitized nerves, like you described, Amy, what happens is that limbic part of your brain is constantly being stimulated. And if you happen to be somebody that's prone to anxiety or sleep disturbances, or, kind of a negative state of mind or depression, we believe that this can actually prime those. And we frequently have patients that come in and will say, again, that I don't feel myself, and they're not sleeping and all that sort of stuff. It's a really tormenting kind of pain. It has no diagnosis. People aren't trained to treat it, and it's just destroying people's lives. When we take away that pain, as you described that Dr. Schmo did with you, using our techniques, you can literally have people, the switch flips in completely the opposite way. They're like, I'm sleeping better. I feel more sharp. I feel more focused, and you kind of feel more, they say that they feel more into their body. And you describe that as the negative way. You describe the downhill, where you say, when it's sensitized, I feel foggy and I can't concentrate and I feel kind of dizzy. And so it's a kind of a two-way street. It's really interesting.
Mm-hmm. And it is. And, like with Dr. Jeremy, like he'd be like, oh, does it hurt here? And I'd be like, I didn't even know that hurt.
Yeah.
It's just like, he just has his way of finding those spots.
Yeah. No, that's, they become really sensitized. And a lot of times, once that's one of the things we do in our approach is we had to go back and really learn, they say that, medical students and people that are trained in healthcare kind of don't sleep when they're in school. And one of the chances they take to sleep is often neurology class. and peripheral nervous system is particularly sleep inducing. And so, a lot of us had to go back and, we had to do that and go back and really look at the anatomy of these things and learn to identify these nerves. And when we do, these pain patterns that used to seem very general, or that we used to ascribe to, the spine or to the joint, we found actually weren't. They were in the general region. But what Jeremy was doing was, by pressing on those individual nerves, he was confirming that by producing that pain, he was like, that's not coming from your joint. I know exactly which nerve that is. And then he went and treated those nerves, and I'm sure you had benefit from that.
Yeah, absolutely. And, and chronic pain is such a common, most people I know who have a brain injury had another physical injury. You're usually in a car accident, or you've fallen, or, there's usually more injury involved. And so I can see where it gets confusing, like, where is that pain coming from? And you start to adapt. Like, if you did injure your shoulder, you walk a little differently to baby that shoulder or that knee or that ankle. And it's just this vicious cycle until you can find someone.
Absolutely.
Like an FNOR, someone that can help you get through this.
Yeah, absolutely. Amy, there was an article that came out this week, which was kind of vindicating for us. And it was an article that talked about in football players. And they found that those football players that had concussions, so they looked at the entire population of the football players in the study, and they found that those that had one or more concussions were actually drastically more likely to have ACL injuries. And ACL is your anterior cruciate ligament, which is a devastating injury of the knee. Your cruciate ligaments are ligaments that are deep inside your knee that stabilize your knee. And for a football player, having a cruciate injury is devastating. It's a very it's a big surgery, and there's big rehab on the back of that. And there's no way that you're ignoring that injury. That is, it's a nightmare for a sports person. So those individuals that that had the brain injuries, the concussions, actually had the knee injuries. Now that vindicates us in the sense that we've been saying that for a while, because one of the most demanding functions of your brain in terms of movement is the ability to regulate muscle tone. Remember, I spoke about that in the beginning, and I said to you that the ability to relax your muscles when they're supposed to be relaxed and to tense them up and stabilize when they should be stabilized. And one of those functions is, if I'm bending down to pick a box up off the ground, what needs to happen is that I need to maintain the tension in my muscles in the legs, but I need to let it out. I need to let it out to the point that my knee can bend. Now, if my knee cannot bend because the muscles are too taut, well, that's not going to work for us. And it's also going to increase compression in the knee. And I'm also going to have to find some other way to get it done, including, by the way, maybe irritating the back. So one of the functions of the brain, and one of the areas that's very dominant in this function, is the basal ganglia, is the ability to maintain appropriate tension in the muscle while relaxing and allowing the joint to elongate. And that particular capacity is used by every human being every single day. It's not only on the sports field, but on the sports field, of course, the intensity is amped up, and you're placed in more situations per minute, I guess, where you have to get that function to switch on and switch off in a big way. Now, that function not only includes basal ganglia, but the eccentric muscle function is distributed across multiple areas of the brain. And what the literature shows is that in injury and in aging, and it's actually quite interesting, because what a lot of the things that happen in aging also happen in brain injury, where these functions that are normally laser focused in a particular network in a particular part of the brain, they break up and they start getting spread all the way around the brain. So what that means is that the quality of the movement and the ability to individually move your joints independently of one another in these complex movements changes. And you can see this, it's obvious to anybody that sees very elderly people, or your family members that are very elderly. You see that they don't move. I was going to say, I went to a rock concert a few weeks ago, and I went to a band that, I don't want to say the band because I don't want to go on record as saying, but it was somebody that used to move pretty well, and I was pretty disappointed that they didn't sound as well as they did, and they weren't moving very well. So not everybody can be Mick Jagger. So, but anyway, so that's an example of, as you age, these changes start happening, and they happen because of changes in the brain, and head injury and concussion can accelerate that. And that's how we believe these factors get merged, such that the head injury, and as you said, a lot of the people that you know always have a bodily complaint, and that we think is more than a coincidence. It's because the parts of the brain that control the body are breaking down, and then you just end up with these really injurious and aggravating forces, such that just sitting up from a chair, or sitting in a chair, or walking, or lying down, or standing becomes aggravating. And those are, innocuous processes. They shouldn't be bothering you that much.
So what should someone who chooses to find an FNOR clinic, what should they expect as far as a rehabilitation program?
Well, there are a few things that are going to make it a little bit different. The first is that the program that you'll probably be put into, and as I say program, some people get treated under our approach for 1 or 2 visits and they're done. It's not that it's an extensive program, but I mean by program is that there's generally a formulated approach that's designed for the individual, and that may be implemented over 1 or 2 or 3 visits. It may be implemented over a longer period of time. But that program is going to involve an analysis and looking kind of at your injury and at your nervous system, and the approach we based on that. The first thing you'd probably recognize if you have gone to physical therapy before, or you've gone to other therapies, is you're probably going to notice that the therapies are a lot more intense than you're used to. And by intense, it means that it's not that you're going to be picking up 1,000 pounds. It just means that what is being done very persistently, and your nervous system has been driven very, very hard. Where a lot of therapy is done in a very gentle way and very cautious way. But we're pretty confident in the areas that we're driving in the nervous system. So we drive very intensely because we have to create that change. The second thing that you're going to notice is that there's going to be things that you are going to do. We actually enter into a partnership with our patients such that most of the work is actually done by the patient. You've got to do the work at home, because some patients will see once every 2 weeks, sometimes once a week for initially, or we like to have a bit of time in between, because we feel that a lot of the work that needs to be done can be done in your own time. So it's going to take a little bit of a requirement from you to do certain home exercises and that sort of thing, which will also be equally as intense. You'll also notice that if you come in with pain, in most cases, the pain is going to go away pretty fast. Sometimes on a day one, we'll have patients have pain freedom that they haven't had in years. Now, that's not to say that that will necessarily stay from day one. That's not at all what I'm promising, but I'm saying that we find that a lot of patients are very surprised to notice that their pain is completely controllable. And oftentimes it's controllable by things that they can do, and very simple measures. So again, so it'll be intensive rehabilitation. Pain will be emphasized because we believe that really, when you're in pain, how can you really do anything? I mean, nobody wants to do anything in pain. You're not motivated to do anything. And a lot of times people are coming in for treatment of pain and they get given a bunch of exercises that they feel that they can do in the gym, in the hopes that the pain will go away. That's not at all what it is. We treat pain as a priority, and you'll see, the emphasis is a lot of a nervous system stuff.
Awesome. Yeah. And, once you can get pain under control,
Absolutely.
it frees up so much more energy.
Absolutely.
You're not just, your body can relax.
No, absolutely. And the pain serves, sits there to torment the individual. It means it's not enough that you can't concentrate or you have the brain fog, but you've also got this demotivating factor that you have this pain that torments you. Like you know that if you start moving, it's going to hurt. And in many cases, but you can't really identify exactly what hurts. And a lot of people come in and say, everything hurts. If I do, everything that I do hurts. And in many cases, we'll go through a process where we'll find actually, well, a lot of times it's not quite everything. It's some things or it's combinations of things, and we can kind of crack that code. And even in people with really bad injuries, we can often find a lot of breathing space very quickly, very early on, to give people hours or big blocks of time where they actually are not hurting. And that's great because that in those blocks of time, even in the early stages before the pain is ultimately gone, you can do a lot of stuff. You can get the things done that you haven't been able to do before. And a lot of times I'd say all the time in pain, the most problematic aspect of pain is not the pain itself, but the disability. It's the sense that you can't get the things done that you need to get done. That's the part that robs your life. A lot of people will say, well, look, if I can get through a day and get my work done or get the things that you're passionate about done, the things that you used to do, if you could get through that, at least get some passion back in your life. And so most people can deal with a little bit of pain. So we also like to track people against capacities, we want to make sure that they're engaging in their life and getting into the things that they're passionate about, because for a number of reasons. One is because we want that transformation to be meaningful to you, because what's the point of getting rid of your pain if you can't do the things you love anyway? So we want to make sure that people are engaging in those sorts of things. But also the fact is that there's certain parts of your brain that are characteristically deactivated or dysfunctional in chronic pain. And those parts of your brain are associated with you deriving pleasure from activities and attaching to your values as a human being. Those parts that identify you as an individual, the things that you used to love and used to do, and wish that you could do again. And I apologize, we got a siren there in the background, but yeah, that was below. So if you are, those centers are in the brain, and they're very commonly affected by the pain process, and kind of short-circuited by that limbic system and those limbic aspects that I spoke about before. So if you can be tracking, doing those things that you're passionate about and engaging in those, that is actually, again, the two-way street. It's not only therapeutic for your brain, but it's a way of tracking, are you really in a positive spiral, and is your brain really adapting? Because it's easy to track things like your ability to focus your eyes on a finger, or your ability to lift 10 pounds or walk 5 miles. But a lot of things that are not being tracked, other than through certain scores and certain standardized scales, is how more engaged are you in your family and in the things that you love, and those are ultimately products of the brain as well. So I like to track those.
Well, this has been awesome. I mean, this is just I think almost everybody watching is going to be able to relate to the chronic pain component after a brain injury. So I thank you so much for being here. Was there anything we didn't hit on that you wanted to? Any parting thoughts of wisdom?
Wisdom, I'm not so sure. A lot of words, I've got a bunch of those, but I think nothing in particular. And I thank you for the opportunity, Amy. And I hope this has some benefit for somebody that is in chronic pain. And I want you to realize that if you are listening to this and you are in chronic pain associated with your brain injury, oftentimes a couple of messages. Number one, the chronic pain isn't there by coincidence. It often is a part of the brain injury. And just like your brain injury, it is treatable. There are things that can be done. In time, the effort that you invest in dealing with the brain injury will often yield benefit in the pain, and it'll be it's often helpful to be dealing with the two at the same time. So a lot of the things that are positive for your brain and your brain injury are going to be positive, and don't be tormented by the pain. The pain doesn't represent an obstacle. The literature often says to us is that, listen, the pain will be there, but if you're going to hurt anyway, would you rather hurt, doing the things you love and have activity, or would you rather hurt being, receding from activity? So, there's definitely a positive message, and there's an opportunity here there. And I hope that the people that are listening to this that are in pain hear that.
Absolutely. So thank you so much, David, for being here. This was great.
Not a problem. And thanks for the opportunity.
And thank you, everyone, for watching. I really hope that you got some great information from Dr. George. This chronic pain stuff, I know it affects so many of us, and it can be so debilitating, but there really, truly is hope. And just always remember, you are not alone in brain injury. And if you've missed any of these recordings, you can definitely purchase all of the recordings for $29. And a portion of those proceeds all go back to the Brain Injury Association of America. So thank you, everyone, for supporting the Brain Health Summit.